None of the producers have any financial interest in any of the products or procedures mentioned or shown in this film. No copyright infringement intended for the music used in the video. Semilunar sign. Embryological development of eye is fascinating. It all starts from day 22 of intrauterine life. The eye is derived from 3 of the primitive embryonic layers: surface ectoderm, including its derivative, the neural crest, neural ectoderm, and mesoderm. The neural crest, which arises from the surface ectoderm in the region immediately adjacent to the neural folds of neural ectoderm, is responsible for the formation of the corneal keratocytes, the endothelium of the cornea, and the fibroblasts of the sclera. Embryologically, the corneal endothelium and the predominant part of sclera are derived from the neural crest cells. This may probably be one of the reasons for scleral inflammatory disorders affecting the cornea. The additional factors for the combined pathologies between the cornea and sclera are the anatomical close proximity, the closely related collagen structures, and the immunological response. The outermost ocular coat sclera is constituted by the interwoven dense collagen, which imparts the unique tensile strength and contour to the globe. The diseases related to sclera are often inflammatory, often associated with collagen vascular diseases and autoimmune syndromes. The common morphological changes on the cornea induced by scleritis are astigmatism, sclerokeratitis, limbitis, and peripheral ulcerative keratitis (PUK). We report the clinical presentation of semilunar sign in scleritis. Semilunar sign was defined clinically by the following criteria: 1. Presence of posterior corneal opacity. 2. Concave semilunar pattern of opacity on diffuse direct illumination. 3. Absence of blood vessels. And 4. Normal anterior cornea. In a study performed by us on the semilunar sign in scleritis, we performed multimodal imaging, which included clinical digital slit lamp photography using 10x magnification, spectral domain optical coherence tomography, and specular count analysis. Active cases were defined when the endothelial opacity presented with pain and redness, and non-active cases were those with healed scleritis with no symptoms. A total of 76 eyes of 72 patients with anterior scleritis were evaluated in the outpatient clinic in the given time period. 15 eyes of 11 patients presented with semilunar sign. In this demographic table, you can see 6 out of 11 patients, that is 54.5%, showed positive MAN2 test. All these patients showed corneal endothelial opacity in the form of semilunar configuration. The opacity involved the endothelium and the posterior stroma as expected. No corneal edema or Descemet's fold noted. All the 15 eyes had scleral lesion, either in healed or active state. Scleral thinning following necrotizing scleritis was noted in 7 eyes. The active scleritis was diffuse in 2 eyes and nodular in 1 eye. Digital images from slit lamp photography images were analyzed by ImageJ software for endothelial surface area involvement. We also performed image analysis showing the assessment of the endothelial surface area. Here is the slit lamp image showing the semilunar sign and the corresponding 8-bit grayscale image with blue-lined area representing the region of interest on the filtered image. The mean surface area of the endothelial opacity was 7.7 square millimeters. The percentage of the involved corneal endothelial surface contributed 5.8% of the overall endothelium. There was no statistically significant correlation between the posterior corneal opacity thickness and the BCVA. MAN2 sensitivity also showed no significant correlation with the posterior corneal opacity. Coming to the endothelial layer in these eyes, there were no keratic precipitates or pigments on the endothelium in these eyes at presentation. There was no correlation between the ECD and the thickness of opacity. The morphology of endothelium differed between the involved and the uninvolved region of cornea. there was statistical difference in ECD between the central and the involved peripheral cornea. You can see a clear difference between the already reported conventional interstitial keratitis and semilunar sign. Watson et al. In their review reported seeing patients with posterior corneal opacity, which they mentioned as indistinguishable from interstitial keratitis of congenital syphilis. Our cases differed from the case series of Holt and Watson by the absence of anterior chamber inflammation, absence of vascularization, absence of nummular coin shape, and the peripheral corneal semilunar location. If we consider it to be a form of immune-mediated response from the cornea, which has triggered the endothelial change, it should have shown response to systemic steroids. However, it does not disappear after steroid course. Thus, the pathophysiology remains unclear. With no vascularization and asymptomatic corneal involvement, it may be entitled as additional clinical sequel of anterior scleritis. It has to be differentiated from closed differentials like viral corneal endothelitis, chronic uveitis, or glaucoma. Since extensive scleral involvement was noted to have more endothelial involvement, early treatment may prevent the severity. Tuberculous keratoscleritis has been known often as scleral abscess and necrosis and not been observed as isolated corneal endothelial opacity. During phacoemulsification in such eyes, certain precautions should be followed. The operating surgeon should take additional intraoperative precautions like proper planning of surgical incision, use of limited ultrasound power, and viscoelastic guided endothelial protection, thereby preventing further endothelial loss. The main objective of highlighting the endothelial sign in scleritis is to create an awareness of a dormant or indolent condition which still on prolonged course can affect the endothelial function. We also insist that the presence of semilunar sign will mandate a comprehensive scleral examination in routine checkup. Thus, we hope that this video has highlighted the corneal endothelial entity of semilunar sign of scleritis and its clinical implications. All pathologies have a cause hidden behind. Some the human brain is able to discover, while some remain concealed in embryology, as in this case.